of all, I just want to say, thank you for your flexibility. We scheduled this on the eve of Yom Kippur, so we had to change the date, and then we sent you out a Zoom link that was incorrect. Anyway, hold the thought. Your flexibility means the world. Thanks so much. So happy to have you here. Please note that the information, this will be recorded, so will be able to be available to people on the Rethinking Schools website within 24 hours, but I would say by tomorrow at noon. In addition, the PowerPoint that Dr. Santora will be sharing will be available as well. And then I just wanted to make note that I did get an email, and I've been able to talk with Dr. Santora from Jen Moore from the 16th District PTA about putting together a forum for families as they consider whether or not to vaccinate their kids under 12. And her recommendation was it can include public health as well as some local pediatricians, and want you to know that Dr. Santora is all in. So we will definitely get something put together. You'll hear a bit later that in fact, it looks like potentially by end of October, we might have vaccination for our younger students. So with that, this is being translated in Spanish as well. And Michelle, if you would mind translating, I would appreciate it.
Sure thing. Este webinar se transmite simultáneamente en español. Haga clic en el botón de interpretación del idioma que aparece en su pantalla si desea escuchar esto en español. Gracias.
Thank you. Thank you so much. So let me go ahead and pass this to Dr. Santora. Thank you, Lisa, for being with us.
Of course, thank you. Sorry you guys had to hear about the trials and tribulations of the playground and Foursquare issues, but that's our world, and I'm so appreciative to everyone that creates those environments where kids can be outdoors playing in mixed groups. So we can jump ahead right to the next slide. And I apologize. This is basically a repeat of the presentation we had earlier, though we corrected some of the slides and have them updated, but there is hot off the press information. When I presented earlier, I showed data that was accessed yesterday, and I got a call from a reporter who said that they went onto the CDC tracker and we were at substantial. So he didn't understand why I was saying we were at moderate levels of transmission. And that's because the CDC is now updating its COVID-19 tracker on a daily basis, rather than it used to update it on a weekly basis. And so from September 6th to September 13th, we earned the award for being first in state to enter into the moderate transmission. And now, unfortunately, we're first in state to go from moderate transmission or yellow back to substantial transmission. And that's due to the post-Labor Day spike in cases that you see by that red arrow. Although it might be we're a little disappointed. This is not unexpected at all. We hope to see a continued decrease in the number of cases on the track that we were before Labor Day, and hopefully people again hunker down, listen, and see that it really is those personal gatherings outside of school, outside of work, when people are indoors at home and having drinks and meals together unmasked, that is driving COVID-19 activity. So you can jump to the next slide. So this is updated from today, from this morning. So we are now continuing to see increased rates among our unvaccinated persons. That's circled there. The case rate among unvaccinated is 31.4. And the unvaccinated population includes 20,000 eligible individuals in Marin County and over 30,000 uneligible individuals in Marin County. So it's around 60,000 people in Marin County who remain unvaccinated. The majority are unvaccinated, 2/3 are unvaccinated by ineligibility, and 1/3 of the unvaccinated are mostly by choice. You'll see our case rate is, Rocco, hey, sorry, I forgot we're presenting now. Our vaccinated case rate remains low. And I just wanted to point to you that when we see these spikes these spikes, it most commonly occurs in that unvaccinated populations. Unvaccinated people are 5 times more likely to be infected with COVID-19, and that's why you see that double spike up on the orange line. So you can jump ahead again. What we follow very closely is how positive cases are impacting our hospitalizations. You may have seen in the news where we're having staffing challenges. Part of our healthcare infrastructure depends on locum tenens. These are people who are not employed by a particular healthcare system, but who travel across the country at an hourly rate to practice healthcare or to nurse. And so what we're seeing is, because of surges in other parts of the country and true crisis or emergency conditions, other parts of the country are offering much higher hero pay that locum tenens or traveler healthcare provider may opt for those higher wages since they don't have benefits connected to being part of a particular system. Right now, our hospitalizations remain stable just due to the high vaccination rates in our community, but this is something we will be closely following in the next couple of weeks. We'll anticipate keeping, because of this spike that I just discussed, it'll be 2 weeks from this week where we see that second peak in hospitalizations. Again, there is that 2-week lag. Jump ahead. And then for this group, I just want to reassure that I know there's a lot of news around poor outcomes in pediatrics or the adolescent and children population. We are not seeing that in Marin County. The data from the nation is showing that the communities that are experiencing higher pediatric rates have higher proportions of unvaccinated persons to begin with. They're often in the Southeast. We see young Black or African-American children and adolescents are at highest risk for hospitalization and adverse effects. And then 3 specific conditions place children and adolescents for higher risk of poor outcomes. That's for obesity, diabetes, and asthma. I'm sorry, it was 3. So those are the 3 highest predictors of a poor outcome from a COVID infection in a child or adolescent. And we're really fortunate in Marin County that we are protected somewhat by our just social drivers of health in the county and lower obesity rates in this county, as well as high insurance rates and access to healthcare of our child and adolescent population. And we have not had a death under the age of 35 in our county. We are moving forward in planning for enhanced booster vaccine clinics. We see this role, this is not an emergency like it was last year to offer vaccinations to an unvaccinated population. We see that this is a role that our healthcare providers will play a critical role in ensuring eligible patients who are seeking a booster vaccine would be providing them in their traditional healthcare setting, as well as our pharmacies. We're waiting to hear this Friday what is the outcome from the FDA meeting in reviewing data on boosters from Pfizer. And we're again waiting from recommendations from California Department of Public Health and the CDC. So in the booster space, we don't see ourselves as a primary provider of boosters like we saw for the initial vaccine series. We see ourselves as supporting a healthcare system to ensure access to timely boosters for eligible and high priority populations. So we've set a goal that 1 month after authorization and recommendation, that wait times for booster appointments will be less than 2 weeks for the older than 65 population. You can jump ahead to the next slide. And the way we're doing that is we're partnering with private entities like Safeway, Rite Aid, and Walgreens. We'll be prioritizing in public health 2 groups, the residents of our long-term care facilities or nursing homes, and then older adults greater than the age of 75. And we're working now to build capacity within all the clinics and healthcare facilities in Marin County, make sure that they are ready to provide COVID-19 boosters to their patients. Jump ahead. So on the pediatric vaccines, again, we see this as a critical role for public health, but we also see that we need our healthcare providers to play a role in pediatric vaccinations. They will be vaccinating a younger group of individuals, and I think that's why it will be important to have a panel with infectious disease specialists and pediatricians so the community can hear from experts around recommendations after we get to review the data and recommendations ourselves. We see this as an individual family decision. And with a younger group that I just described has much more asymptomatic or mild disease, we know many parents will be weighing the risks and benefits of vaccination. We're not anticipating this until the end of October, but we do anticipate they will be approving the pediatric vaccine. And so we're on target to launch our first pediatric vaccine clinics starting October 28th. Unlike the booster shots, we are setting a goal to vaccinate 75% of newly eligible children. Well, not to fully vaccinate, but for them to receive their first dose within 1 month of authorization and recommendation. And we'll be, again, supporting providers as well as having school-based vaccine clinics and what we call our Super Saturdays. So families can drop by and get their kids vaccinated at specific sites to increase access to vaccinations. Mary Jane, do you want to jump in on this slide?
Sure. This is just a sample of what we're looking at in terms of what the dates would be, first dose, second dose, and you can see the goal here is trying to ultimately, prior to the winter recess, having, as Lisa's mentioned, 75% of our eligible students whose families want them to get vaccinated, we're ready to go. Just to note, during this timeframe, we will definitely be looking for volunteers that would be willing to help support. We have some sites that we've used before, i.e. Miller Creek. Novato is offering up either Hamilton or Novato High School, depending on football, and then we'll have something in Southern Marin. So just know that we will be prepared to take all the steps that we need to ensure that we're able to make this very, very successful. Do know that educators from public, private, independent, and parochial schools were unbelievable in their willingness to volunteer during the vaccination clinics for our school staff, but we'll reach out to you all in the event that we need some additional volunteers. So the point of this whole slide is that we're definitely on it, we're paying attention, and we'll be ready to go as soon as we are eligible to move this forward.
And just, we will be vaccinating in West Marin. I saw that not mentioned. We have a strong partnership with Petaluma Health Center, Coastal Health Alliance, and we'll make sure that there's access across the county. So I just wanted to share this start. So that's kind of the end of the public health update. And now we're going to shift into the schools update section. I just wanted to share this graph with the community to see where our brains were when we were moving forward with planning for the start of school and what we're continuing to see now. So just to give you a frame of reference, you're looking at different colored lines based on the ages. So starting from the bottom, that blue line is children between the ages of 0 and 4. The orange line will be children, again, these are ineligible populations, children from 5 to 11, then our 12 to 18 population in red, and then the over 18 population. And so you'll see consistently throughout this pandemic, we have seen that children are represent a very small part of total cases in our community. The majority of cases in Marin County are among adults over the age of 18. And the majority of those cases are among the 18 to 35-year-olds age group. Unfortunately, that age group, though they have the most cases, do not have the same levels of hospitalizations and fatalities. So that's good news. So what we saw in May, what shifted us towards a more conservative approach towards opening school, is if you look at May, you see a case rate, but in May, we were only seeing around 2 cases a day. So when we had a large outbreak at a school site driven by the Delta variant, you see a jump in those in the percentage of cases represented by children. So this was our first encounter with Delta in the school environment where we saw an outbreak setting. And it definitely humbled us to the nature of this variant and also shifted us. We were anticipating starting the year with only a 10-point guidance because we thought we were done with waves and we kind of cleared this. Delta was a game changer. So that's why we entered the year with a much more conservative approach, with the concern that we would see a similar surge in pediatric and adolescent COVID-19 cases if based on that one outbreak. And again, I know there's a lot of questions. Unfortunately, we do not have, there's a lot of questions about the data and evidence that's informing our policies. Policy making in a pandemic is complex. Ideally, we have randomized clinical trials where we can see what a control group looks like and what a case group looks like, but in real life, we don't have that. We have our local data and local information. We scan both state, national, and international data to make the best information. And again, that's why we shifted towards a more conservative approach as we knew we were entering the school year with in a fourth wave with the Delta variant circulating at much higher levels. So you can jump to the next slide. So we doubled down. That's what we do. We knew that Delta was with us, and we knew we just needed to further fortify our partnership with the Office of Education and all of the leadership from our public school districts and private and parochial schools. We have an overarching goal that all schools and classrooms remain open for in-person instruction, and an important secondary goal that we reduce the educational attainment gap that we knew widened during this past year and a half, as lower income students did not have access to the supports and resources that they needed to maintain those levels that are critical for educational attainment. So we doubled down on our efforts and strengthened our partnership. We didn't have a 10-point plan like we're hoping. We actually upped our game and added a 32-point plan and developed a mitigation strategy. And so we entered with our mitigation strategy where indoor masking was required and outdoor masking was recommended. We had a secondary update after lessons from the first 2 weeks of school where we introduced recommendations around seating assignments for lunchtime. We saw lunchtime exposures as being a vulnerability, especially if that's when kids are unmasked, talking and eating face-to-face. And so it increases that risk for exposure. And we also made the recommendation to shift all large gathering outdoors while we were at the highest phase of that Delta surge. Last week, we issued updated guidance for sports and other performing arts and high-risk activities. And I'll have another slide to describe that more. And then we have another slide to describe our collaboration to expand school-based testing in our school sites. Jump ahead. Anything you want to say there, Mary Jane, before we jump?
No, I think that's good. Thank you.
So this is will be a link to all of the resources that we have currently available. We have 2 updated decision trees for you to see. One is just a symptom decision tree in all settings, and then another decision tree for childcare and some household contacts, not for the TK through 12 schools. You can take a look at that. We will be updating our exposure decision trees just to make them more user-friendly. Again, from lessons learned, we're seeing a lot of people really do like the updated decision trees, some of the simplicity they have. So you can jump ahead. So this is the updated school and youth performing arts, sports, and extracurricular activities. Masks are required for all indoors. Sorry, I can't read my hand right. Can't even read. It's been a long day. Indoors for all participants. There are exceptions, for example, water polo and swimming, and where there may be a choking hazard if a mask is worn indoors. Otherwise, masks should be worn indoors. We are recommending limiting high-risk performing arts, sports, and extracurricular activities, especially when indoors, to youth who are fully vaccinated. So that's for eligible youth who are fully vaccinated. We know that's not feasible for younger groups. And so then we recommend regular testing of unvaccinated participants and staff, including volunteers and coaches who are engaging in high-risk activities. So this is the first, a lot of questions we have been getting throughout the year or summer and into the school start of this year has been, why are we not recommending asymptomatic screening for students? We don't recommend asymptomatic screening for unvaccinated students generally because it's very low yield. We have had experience last school year with pool testing at some school sites and with regular testing programs, and it does not identify cases. We are now making our first recommendation for asymptomatic screening of unvaccinated persons for those students and staff who are engaging in high risk, not staff who are unvaccinated are in a different testing program, but volunteers and coaches who are engaging in these high risk activities that are listed below. And so we have the link in the chat so you can take a deeper look at that guidance. Jump ahead. You want to field this one, Mary Jane?
Sure. So just for everybody to know that because of our public health, I would say the way Marin Public Health is held in high esteem in the state of California, that we have been selected to be part of a statewide pilot, a pilot in our state. Actually, I think we're the only one. And essentially what this is doing is that we are trying to determine how is it that we can do a pilot of antigen-based testing, that we can get a test to every single parent for their children, every single staff, so that in the event that there's symptoms, they'll be able to test, provide information, and we would know in real time whether or not we have a COVID positive situation. And even in the school site, that there would be antigen tests available so that if there was someone who exhibited symptoms at school, that we'd be able to get the results immediately. Back to the basics, just a reminder how important it is that teacher staff, all school staff and children, as students stay home if they're sick, right? And so we're trying to facilitate a way for families to get information and to provide it to the school. So we have right now, I think it's 9 schools that are currently in our pilot. And so they've been willing to raise their hands and work out the glitches, if you will, about what we need to do. Like, is our video good enough? What about our letters to the families? Is the information provided going to be strong enough to move this out? But just to know, our hope is that every school in Marin County, public, private, independent, parochial, will in fact be able to roll this out by the beginning of November. So we are definitely in a situation where we're going to try to do everything we can so that our families have this information. Requirements from the state, though, that's really important is that we have to do strong data collection so that we have information about what the data is showing us. And so if you go to the next slide, you can see this is where we are now. So we're not that far along, but you can see that so far we've been able to distribute 6,000 individual tests to the 9 early adopter schools. And note, it's being repackaged and distributed to families and staff. So if you have seen the Binax blue box, it comes with 2 tests in it. And when we first received our supply, we believed that we would have enough supply that would continue to be coming for us to give everyone the blue box with 2 tests in it. And as it ends up, that we've needed to repackage it into packs of 1 test so that, you know, each family would get 1 test, not 2. And right as of right now, and we're just starting, we have 167 tests reported, 166 are negative and 1 is positive. So the important thing about this is that these are tests that are being given solely for students or staff who have a symptom. And so that gives us, you know, more information. We'll be triangulating the data because the survey that people need to fill out actually asks what the symptoms were. You know, was it a fever? Was it diarrhea, et cetera, et cetera. So we'll be helping the state, you know, look at this data. But do note that it is our plan to continue to get supply. But do note that as the supply is distributed, we will be first making sure that it will go to our schools with students that are not yet able to be vaccinated. So that will be a priority. And then the next step, I mean, in addition to make sure families that have not had access and cannot get access to these tests. As you may know, if you've tried to get them, not easy to get and actually quite pricey. So we're going to be working on this.
I just want to talk about supply for testing. That is our main issue. We have 39,000 students in our school system, and we had 3,000 tests of the Binax home testing kits that we doubled, and by repackaging have doubled it to 6,000. So this is a national challenge that of accessing Binax supplies and these rapid antigen tests. So it's not it's not a will issue. The will is to have our vision and will is that every student does have access to at least 1 free home kit for testing. The challenge is the national supply. We're very protected in California. And if you see where there are significant surges across the country in cases, we see different allocations from the federal level down to the state and then local level. So that's for free supplies. These are costly supplies, so we have benefited from having access to these free testing supplies. More tests are coming. We were originally told to be 2 weeks, but now it's up to 8 weeks. So again, that's just something that we have to navigate. We are as far ahead as we are in the game in California. This is still a significant pandemic, and surges are being experienced across the nation. And so that's just part of the landscape that we're navigating right now. And I just want to point out one thing on this slide before we jump ahead is this group is considered a group with high pretest probability for a positive test. And this reinforces our recommendations around not just screening or surveillance of asymptomatic students in a group that, and again, it's a small sample size, only 167, but this is a group that was symptomatic or may have been exposed, and we only had one positive test. This is important though. I think this is the vision of the future, and I think it's beyond my imagination that in a year and a half that we'd have home-based testing like these cards that you see. It just shows how fast technology has evolved, and the will of, I guess, the capitalistic spirit will too in our country to develop and manufacture these tests. And then we do have a greater access to what we call our 40 boxes, which are these are rapid antigen tests that we see every school site having at least a box of 40. So if someone becomes symptomatic in the school, they can be tested. If someone needs assistance for testing for modified quarantine, they can be tested. And this is where we're expanding our resources to make sure every school is trained and equipped to perform rapid testing on the school site. So people may not have the home kit, but we do have those 40 boxes that just can't be, we don't have enough of those either. We don't have 3,000 of those boxes left too, but that's obviously a larger number when you have 40 per kit. And we have enough boxes to distribute to all the schools in Marin County. There's only one small, in those 40 boxes, only one small vial. That's the gold. So we can't repackage those boxes to distribute them for home-based testing.
And Lisa, I think that the note is that as the state looks at the data, as we provide it, they're going to want us to have more supply, because the more data that we provide to them, the more insight they'll have about what's the best next step. There was a comment in the chat I just want to address. It was a comment about, well, why haven't you had testing available? This is not to take the place of other testing that has been available. We have had PCR testing available all along, and testing that's available through healthcare providers, et cetera. But one of the challenges with the PCR testing is that we were getting the results approximately 48 to 72 hours after the staff person or child's tested, and it is more efficient, effective, and easier to track and trace if we get information within 15 minutes. So I don't want anyone to think that there hasn't been other testing available in the event that we had someone with symptoms in our schools.
Jump ahead. So this is our updated dashboard. There's new information that was not on the dashboard last year. If you look on the left-hand side, you'll see reporting around our vaccination rates. We're going to be reporting on the percentage of staff who are vaccinated and the percentage of eligible students who are fully vaccinated. And then you'll see the percent of schools that are reporting. We've set a deadline of October 1st for all schools to report, so our community can have a full picture of the vaccination status of our community. And then you see on the right-hand side, it's not any different. We're reporting the number of school-related cases. So the top two numbers are students and staff who are identified as being on site during their infectious period, which is 2 days before developing symptoms or 2 days before a positive test for someone who's asymptomatic. And that's what initiates our investigation of a potential exposure event and identification of close contacts to those positive persons. The promising picture on those first two numbers is the effectiveness of the vaccine in preventing infections among staff. Last year, we had a much more balanced picture of students and staff who were infected. So this to me shows the protections offered by vaccinations. And so that's a good thing, is that we are starting the school year with staff and many students being eligible for vaccination. And then we are continuing to report on the type of transmission that we're seeing. And not surprisingly, because of high vaccination rates among our staff, we're not seeing the staff-to-staff transmissions that we saw last year. We're seeing more student-to-student transmission. So
Lisa, just to add one thing, The number there about the number of eligible students who are vaccinated. So the 81% represents fully vaccinated. We actually have 90% who've received at least one dose. So we should expect that number to go up.
Yeah, and Marin County as a whole today, although we jumped back into substantial, we now have 90% of all eligible residents over the age of 12 are now vaccinated in Marin County. So we are excited for reaching that threshold.
So a question just came up, and I have the same question. When do we get to say we have herd immunity when we have numbers like that?
Well, we don't, because Delta changed everything. So what Delta did is Delta, and again, I think we are so far ahead of where we were in 2000 when we were managing SARS as a global pandemic. And we now have access to technology for sequencing. So we know, we didn't talk about variants in 2002 around SARS. There were SARS in other parts. It affected Canada more, and Asian countries more. And then we had MERS affect some of the Asia again in, I think it was 2016. So we have experience with these type of viruses, but we've never had this level of sequencing. And then what we've now learned with Delta and what we're experiencing while we had this fourth wave is with this particular variant, which developed in a large population center of the world. It developed mutations at the exact location where the vaccination is targeting. And so that's what we need to be prepared for as a community, is just like the flu. And this is again, you'll be hearing us talking about the shift from pandemic to endemic. So just like the flu was a pandemic in 1918, the flu is now has seasonality. It's a virus that just circulates at low levels across the globe, and then has spikes at certain seasons. And the season for us is typically January or March for the flu. We will see with our aggressive vaccination rates globally, because really this is a global pandemic. And even with SARS, we didn't see this level of infection across the globe. In 2002, we were relatively protected in the United States. We'll see where our global vaccination efforts are successful, and also how technology may be successful. We know that there now is a mismatch between our vaccine that we have available to us and the Delta variant. So I think I'm still hopeful that in a couple of years that that COVID regresses into not being an active infection, but only the future will tell. And so we will have, so at this point, it's a moving target. And I know that's frustrating, but it is a moving target. And we learned that when it became really concerning for us. And again, we were humbled by Delta when we saw with that large school outbreak that there were breakthrough cases. We weren't expecting the level of breakthrough cases that we saw. The good news is that we consistently see that those who are vaccinated and infected, unlike before when they were unvaccinated, are not having severe disease and are not requiring hospitalizations. 90% of our hospitalizations remain in unvaccinated individuals. And again, it's a younger population, people between the age of 30 to 50 years old, who are underestimating their risk, and they're underestimating the severity of COVID. So it's a moving target. And I think we will be one of the first counties and states to have endemic circulation. And I'll talk a little bit more about that later. But I know that's frustrating for people. I too thought come May, we were going to just need 10 guidance and it would regress. COVID would regress, but that's not what was in store for us. Jump ahead. So I just wanted to provide a year-to-year comparison because there's a lot different. And I know the numbers can be maybe startling to some people to know that we had 119 cases we've investigated to date, but we're living in two different times. In January 15th, we were under a stay-at-home order. We were still under the blueprint where we had very, very limited activity. Students were recommended only to participate in no more than 3 activities, one aftercare program, 1 martial arts in school. Like, it was very limited. Being in school also was very different. All kids were 6 feet apart. It was a hybrid environment for most students. Only 17,000 students were back at school by January 15th. And when they were, it was usually only 2 days a week. And flash forward to today, where we have universal masking, but no physical distancing. We have almost 40,000 students in school 5 days a week, full time, all day long. So not a shortened session. And we are on track for having very similar number of exposure events and very similar number of school transmissions. So I'm really proud. This is significantly less than I would have expected. And this is very reassuring to me that the mitigation strategies that we've put into place are effective, and we have been able to create a safer environment in our schools. And what we're consistently seeing is that people do not get infected typically at work or at school. They get infected on Labor Day weekends when they go and socialize and go indoors with families and friends and eat and drink without masks. And that's when we see COVID-19 get transmitted. You can jump ahead. So this just is in summary. We bump back into substantial, but I do see the fourth wave ending. We are preparing for a post-Halloween fifth wave. We know the behavior of our community. There is some predictability to our behaviors, and we know we like celebrating Halloween, and the week before Halloween, the weekend before Halloween, depending on where it lands, people start indoor festivities and celebrating. We are anticipating there'll be families gathering indoors with unvaccinated kids, and we'll start seeing those increases of COVID-19 cases and then breakthroughs into the adult population, into the adult vaccinated population because of the waning immunity they have. We're preparing for new variants. So Delta is here, but we're already seeing it mutate in our own community. So the original Delta, as it started in Marin County, is not the same Delta that's being sequenced now. There's different mutations that we're seeing. So we think that's going to contribute to the that Halloween wave. And then just to remember that by that week before Halloween, there won't be any children under the age of 12 that have received an initial vaccine. So it'll take at least 5 weeks from that first dose for a child under the age of 12 who's to be considered fully vaccinated. So that is going to be something that I believe hopefully shortens that fifth wave so that we don't have that crescendo that we saw in January of last year, where we had surging activity in our nursing homes again. We had our highest hospitalization rates. We are not anticipating that. We'll be prepared for that, but that's not what we're anticipating. And just again, we're shifting from pandemic thinking to considering this endemic circulation. It will depend on the vaccine penetration and effectiveness among these newly eligible groups. So we are just waiting like you to see the data that Pfizer presents on the children that participated in those clinical trials. We'll also be looking at the effectiveness of these boosters. Remember that the vaccines that we have are a mismatch. They will boost immunity, but that's something we'll have to look at, and we'll see in real time what that looks like. And then we're always will remain vulnerable for at least for the next, I'd say 2 years. Because if you think of the challenge of global vaccination with different variants circulating at different parts of the world, we will remain vulnerable to the introduction of new variants, especially when they hit unvaccinated populations in our county. So we do have that vulnerability.
Yeah,
Go ahead.
Sorry. No, I was going to ask you to clarify the term endemic, just so everybody's clear about what that means.
So endemic means the virus is just circulating naturally in our community. The flu is endemic in Marin County. It comes even in the summer. Sometimes we see flu. It just is at a low levels. And then what we see happening in the wintertime is we start seeing those increased levels of flu A and flu B activity. And so endemic just means that there's established low levels of infection in a community. It looked like endemic to us when we were only having like 2 cases a day of COVID in May. That's what I thought we were approaching. Again, I did not anticipate the Delta wave that we saw. We thought that our vaccination rate would hold us protected from a new variant this early in a pandemic. It doesn't seem early. I know it feels like a long time, but that did not prove to be true. And that's where, again, viruses are by design. By design, viruses evade our immunity. That's what they do. They mutate, they learn, and they mutate, and then they figure out how to be either more contagious, more lethal, or again, how to evade both natural immunity and acquired immunity.
And Lisa, this is not going to go under age 5 at this point. Is that correct?
We are not anticipating that. Again, this is all, there's no data that I have not seen any published research myself. I scour the news. I don't have enough hobbies. And so I have found some willing doctors who are clinical leads of some of these research projects. One was out of Duke, who provided some comment to the press. I'm surprised that she did that, because that's frowned upon by the pharmaceutical entity. So we haven't seen the data, but from that, it's just from like kind of this whispers where we start hearing the age groups that's considering. They have, the clinical trials are in all children. So they have done clinical trials as well in the 0 to 4 population. And I think it really is in these clinical trials, but the way they're set up is they have a case group and a control group. So the control group receives no vaccine, and they compare it to the group of children who receive vaccine. The other chart I showed you that shows the low rates of COVID activity already and the pediatric population being low is why it has taken so long to, it'll take more time for a research trial to show if there's any statistically significant difference between the control group and the vaccinated group. So I think that's why we're seeing it's taking longer for these younger age groups, because there aren't the same levels of infection that we see in the adult population and the pediatric population. But again, there's no research paper that I have looked at to be further informed than just trying to scour and read tea leaves of the information we're getting.
So Lisa, as you jump to the universal masking, so there's multiple questions in the chat that is they're framing the issue of people, why aren't you doing more? Why aren't you requiring social distancing? Others that are framing, why is it that you're continuing to strongly recommend masking outdoors? When will that be over? So could you just talk a little bit about that from your perspective?
I think we're striving to balance optimizing the learning environment for the academic, social, and emotional development of our children, and then trying to reduce the risk of COVID-19 transmission, and also to manage what I didn't mention on the slide where I showed, like, try to provide the apples to apples comparison. That number of cases that we managed was over almost a 4.5 month period of investigating cases, where the equal number of cases have been investigated in a 4-week period. And so we need time for our schools to develop an infrastructure to optimize their ability to identify cases and engage in contact tracing, so we can identify the true close contacts of an individual and quarantine those individuals, and then identify close contacts who have been wearing masks. And mask is the difference between a quarantine at home right now and modified quarantine. And then identifying those vaccinated students who just need to monitor for symptoms, knowing we're having breakthrough cases, and that's our reality. So we're trying to balance, one, we do not see school as a driver of COVID-19 at the community level. Our testing events, we've tested now more than 1,000 students in these exposure events or rapid response testing. We're not finding significant number of cases there, which is great news. So schools are safe. So we don't think we need to have 6 feet distancing. We're showing that universal masking, symptom screening. So the number one thing that drives me crazy is that people are going to work and going to school when they're symptomatic. Like, that's consistently what we hear when we investigate our cases. Yes, I had symptoms. The symptoms were disregarded for a multitude of reasons. And then they get tested because the symptoms don't get better. And then they miss the opportunity to reduce contact. We err on the side of caution by investigating 2 days prior to that symptom period or that diagnosis period. So it should be a lower risk because we're still trying to catch a broad net, but we're also trying to learn from our own lessons and follow state and federal guidance ourselves. So we are reconsidering if we consider outdoor exposures as an exposure event or not, because in our testing of nearly 1,000 people, we haven't identified cases of kids who are eating outdoors together. But also wearing masks outdoors simplifies the investigation of these 100 plus exposure events, knowing that once the kids are not eating, they're running around. We don't have to identify those close contacts. It's a lot of work on school staff and public health staff to identify those close contacts, determine their disposition, and again, trying to keep all of these classrooms open. So, sorry, that was long-winded.
Yeah, that's good. Hey, can somebody help me? There's a question that just came in Spanish and I'm unable to translate that. So can someone help me?
One moment, Mary Jane.
Thank you.
Oh, is there another quarantine? Sí, hay dos tipos de cuarentena. Un tipo que se expuesta a un estudiante quien tiene la infección de coronavirus, pero la expuesta está en la escuela y tiene las cubiertas, puede continuar en la escuela. Es un tipo de cuarentena. La otra es si no tiene la máscara, necesita tener la cuarentena en la casa. Pues hay dos tipos de cuarentena y nosotros ahora mismo estamos tratando de bajar la cantidad de cuarentena en la casa para mantener a los estudiantes en la escuela.
Okay, so now Michelle, you can translate that into, or Lisa, translate
Okay,
that
so there's
English.
there's two types of quarantine that we're trying to navigate. One is the modified quarantine. So if a student is exposed at school, then they're wearing their mask, then they're considered a close contact, they can stay at school. And the other type is if a student is exposed at school and they're not wearing a mask and there's close contact, then the recommendation is quarantine at home. And right now what we're navigating, what we're learning, and I appreciate the frustration of this, is that we're learning, our goal is to never exclude any student from school. Now that we are seeing, even though the state guidance is an outdoor exposure masked, close contact should be a true quarantine, we're going to probably be shifting and saying that should be a modified quarantine because we're not seeing transmission in the schools. So we're trying to learn on the ground, again, how we can optimize the number of days that students are in school.
So Lisa, there's a lot of people on this call that don't like masking outdoors. All right, so let's just go with that. We're strongly recommending it. Most of our schools are implementing it, not all. Do you have an idea of when it would be that potentially we would move on the continuum and that you would be saying essentially outdoors, okay, indoors remain masked?
So it would be low, when we move to low to moderate transmission levels is when we're anticipating shifting to the mitigation B, where outdoor masks would not be strongly recommended. There may be families though that know that they have young, like for example, my daughter huddles very closely together with other little girls on the campus. And there may be families that feel more comfortable with their unvaccinated child because they know just the behaviors of their child on campus that they do wear a mask when they're outdoors. And we want to support that. But we anticipate when we move to low to moderate transmission levels, as long as we see, continue to see low levels of hospitalizations and continue to see what we're learning, which is we're not seeing outdoor transmission on the school environment. So we are always ready to make adjustments. It's right now, it's very helpful with the number of cases that we're investigating on the campus to be able to exclude an entire playground investigation for close contact.
Okay, sorry. Are there any other slides to go or can I keep going with questions?
Questions?
Okay, good. So let me just go. So here's a good one. I'm curious how you can allow open lunches at high schools where the kids are forced to go to restaurants and supermarkets, exposed to even more people, including unmasked. It seems so counterintuitive to the safety on school at school and could be streamlined at the school site. So the person who asked this, I just want to say I am a supporter of keeping our campuses closed, not very popular. So I would agree with this for sure. But Lisa, any comments on that?
We are considering again looking at vaccination rates at certain schools. So I think that will be the time that we do pause is on October 1st when we're able to look at the full vaccination rates of by each school. Right now, the vaccination rates that we're reporting is just for the total population of the 12 to 17-year-olds. And so I think what we would consider is early, allowing if a school has very high vaccination rates among the students is to have outdoor masking optional, recognizing we're not seeing transmission outdoors. We really just are, when we have seen transmission of those cases, it's typically been when there's indoor close contact of an infected student to another student.
Okay.
Our behaviors are complex. Again, our goal is to minimize the burden. We want to first reduce the risk of COVID-19 transmission on campus, but also second, to minimize the burden of the investigation of COVID-19 cases on campus by trying to, again, learn what we're learning, and then we'll, again, make those modifications. But some of those recommendations are just very supportive to us as schools are building their capacity to investigate cases and learn how they can have better systems in place. And we don't,
Okay.
and I mentioned this earlier, we don't do this with strep. There's other cases there's other diseases that are out there like flu and strep. We don't have the same approach. And our hope is that when we shift towards endemic circulation, we'll be more in the space where you would receive a notification from your school. You'll be notified that there was a COVID-19 case in your classroom, like you're notified for strep. You then, as a parent, will be monitoring for symptoms and getting your kid tested if they develop any symptoms themselves. I do anticipate masks will be worn indoors in schools for the remainder of the school year, but maybe that will change. Things always do change. But that's what our future hopefully will look like sooner than later. We just need more time.
Lisa, why aren't you mandating physical distancing for unvaccinated students?
Because masking works. Because we want to optimize, our priority is focusing on kids' health and well-being and their educational experience. And we are showing consistently now with more than 3 weeks, almost 4 weeks a month under our belt. We're not seeing school-based transmission. Masking are proving effective, and we are demonstrating success. So I think that's why we're not physical distancing. Really significantly hinders the ability to offer full-time in-person instruction for all students in Marin County. And again, the masking is proving effective.
Do we have, and this is a question, I guess, for me, do we have any unvaccinated teachers and staff? If so, why? So at this point, the schools are reporting the information about students we can get through the county data. So that's how we know that it's 81% and 90%. Related to our teachers and staff, the schools are currently reporting, and as Lisa mentioned, by October 1st, the data is showing we are somewhere between 95 to 98% for teachers and staff. So what we have found, or what I have found, is that like anything, like the nursing profession, by way of example, there were people that were hesitant in the beginning about whether or not they wanted to access a vaccination. And we have found that more and more people have actually accessed their vaccinations. And we're also seeing that the option for employers is to make a determination to actually require vaccinations for staff. So just know that we're going to, continue to work on this issue. The challenges for staff come into a couple of areas. One is that the parents want to know if their child's teacher is vaccinated, and staff who are working with people who are not yet vaccinated don't want to work with people who are not yet vaccinated. Lisa, can I then jump to what is the data showing about any breakthrough cases for students or staff that are any of the data that you show? Were they actually vaccinated?
Yes, we are having breakthrough cases in Marin County. On any given day, it could be up to 50% of total cases could be breakthrough. What's concerning to us is that we're seeing breakthrough cases in adolescents. And adolescents, if you remember from the data, that when it was against the Alpha variant, so now we're on to Delta, they were considered supercharged, like they had a really high immune response, higher than their comparable age group. It was the 18 to 25-year-old age group. And also our adolescents were vaccinated much later than most of us adults. They did not start getting their vaccine until May. So that to me shows the mismatch of the booster to the Delta variant. So that is something that we're following closely right now. Fortunately, we don't see high levels of hospitalizations in our pediatric and adolescent population. I think it's probably, I'd have to double check, it's less than 10 total, but I'd have to confirm that. We have a very extremely low hospitalization rates for the pediatric and adolescent population,
Mhm.
even with the Delta variant.
So Lisa, there's a question here about why was hand washing removed as a protocol recommendation? So I can take that. It wasn't removed. Hand washing is very important. COVID, no COVID. It was just the structure that you didn't have to change a student's schedule in order to ensure that it happened, but you needed to make sure that it happened, because what was happening is the structures in some of our classrooms were changing as a result of the hand washing. Anything else to say about that, Lisa?
Wash your hands all the time.
Yeah,
So,
exactly. Well, and,
no.
you know, I think we get to the basic mitigation strategies for all of us, you know, and it is basic, but not everybody sees it that way. You know, number one, if you can get vaccinated, get vaccinated. If I had the power, I would say you must be vaccinated. So number one. Number two, make sure you never, ever, ever come to school as an employee or a student with symptoms, right? And number three, wear a mask. I mean, those progressive mitigation strategies worked for us throughout last year. And it is the reason why we are the only county in the state that actually has our schools open and the ability to actually use the quarantine that is a sort of a mitigated quarantine, but it has to do with those basics being in play.
The only other thing I want to point out, though, is there are breakthrough cases, but you're five times more likely to be infected with COVID-19 if you're unvaccinated. That's the difference in the case rate, where you see more than 30 cases per 100,000 among unvaccinated today, and only 6 cases per 100,000 among vaccinated. So that's consistently what we're seeing. And the most common story we hear is the index case of our exposure events are unvaccinated individuals. That's our most common story of the exposure events in Marin County. Is it starts with spending time with unvaccinated individuals in private social gatherings. And again, we are demonstrating that school remains a safe place to be, even with the end of 6 feet distancing and cohorts. And remember, we were very structured. Kids couldn't play Foursquare on the playground together, like my son described here earlier on the call. We're allowing kids to play outside, mix with grade levels, run amok, and then have a much more structured indoor environment. Again, our goal is to get, I am not a fan of masking personally. It's not my agenda, but I have seen the evidence, and both firsthand from our exposure events and also from the data, that masking remains an effective tool for us, especially in that indoor environment.
Lisa, has any child under 12 needed hospitalization due to COVID in Marin?
Yes.
And
again, the total number of pediatrics has been, I can get the exact number, but it's been, I believe, less than 10. We do not have significant hospitalizations, and some of the hospitalizations, we had early counts where they had COVID-19 because everyone was just getting tested in the hospital, but that's not the reason they were in the hospital. So there's some mismatch in hospitalization data of whether someone was just diagnosed incidentally.
Lisa, this has come up a couple times, but it has to do with the issue of mask wearing, and if students are not using the right kind of mask, number one, but number two, that not wearing it properly. And so I would just want to say to all of us that that's all of our responsibility, that it's part of the sort of the structure. And one of the things that's in our 32-point guidelines is that we want to make sure that we're using the educational environment to help students understand the why behind appropriate wearing of your mask, that it actually matters. It protects you, it protects others. And it seems as though when we use those strategies, we see kids wearing their masks appropriately. But I think anything else about that, Lisa, because one of the things I forget, is it called a gator, that there's concern about students using the gaiter as the mask as opposed to another masking face covering strategy.
Yeah, we provided that instruction again at last week's public health liaison meeting. We were getting concerns, reports from parents about poor mask wearing and not using the recommended mask. So at our last week's public health meeting, we reviewed the Department of Public Health's recommendation around what is the best well-fitted mask and what is not considered appropriate on the school campus, and that would be the bandanas and gaiters. And we also talked about toggles, which are those little things that pull the mask behind your face. And so just showed, and again, it really depends on the parents of that school campus and on the teachers and the staff all working together to watch, to nudge people when they're not wearing the right type of mask or not wearing it correctly. So,
okay. So Lisa, we're there. So bottom line, just for everybody, you're going to get more information. This will be available to you to share with your friends. Please do so. We will be putting together a panel to help families make a determination for themselves about whether they want to move forward with their own children being vaccinated. So it actually happens that I meet with Dr. Santor tomorrow morning about a variety of issues. And so to all of you, thank you very, very much. We appreciate your questions. And just a note, this meeting is scheduled every month. So we will continue to do everything we can to help you be informed. Lisa, do you have one
I just
more
want
thing?
to answer one question. I understand there's a question about what we are counting compared to the CDC. We count all cases. We count breakthrough cases being hospitalized. We count unvaccinated cases being hospitalized. The data on our website is accurate around all cases. There may be a disconnect between what's reported by the CDC and the state and the county, but if you go to our website, we report all cases. We build trust by being transparent, by sharing our data, by having meetings like this, by being responsive, and also by making changes. We do listen to feedback, and we do scan the research, and we appreciate when people communicate with us. And so we're ready to adapt, and we're ready to move to our new normal as soon as the data and science supports moving to that new normal.
And so let's do a big thank you to Dr. Santor. This is her third meeting. Yesterday afternoon at 4, we had a meeting with labor partners. Today at 1 for the community in general. Tonight for all of you. And tomorrow she's meeting with us, the rapid response team at 8 a.m. So Lisa, you're a rock star. Thanks everybody. We appreciate it.
Take care.